PQRS reporting for 2016 and preparing for MACRA and MIPS in 2017 webinar. My name is Mike Saperstein, Marketing Manager with Spectrumetics, and I'll be taking you through the presentation. Before we begin, I'd like to go over a few housekeeping items. At the end of the webinar, there'll be a brief Q&A session. Feel free to enter your questions in the webinar control panel anytime during the presentation, and we'll address them at the end. Additionally, there'll be 2 short breaks throughout the presentation for poll questions. We would very much appreciate you taking the time to answer them, as they help us refine our webinars and provide even more meaningful content going forward. And post-webinar, we'll be sending each attendee a follow-up email containing highlights from the presentation. Next, I would like to introduce our 2 panelists for today. First off, Dr. Raj Lakhanpal, the Chairman, CEO, and founder of Spectrumetics. He is also a member of the HIMSS Clinical and Business Intelligence Committee. Previously, he founded Health A to Z, an online wellness and population health management platform, which assisted health plans and their clients to reduce healthcare costs. Dr. Lakhanpal is also currently on the Board of Trustees of the University of Sciences in Philadelphia and is a Fellow of the American College of Emergency Physicians and the Royal College of Physicians and Surgeons in the United Kingdom. Next, I'd like to introduce Mark Bryant. He is the Director of Sales here at Spectrumetics, and his role is to bring in new development and client relations. Formerly, he was with Sun Microsystems at Iron Mountain and brings great experience in the information management and technology space. Next, our agenda. First, we'll be going through the requirements and deadlines for 2016 PQRS reporting, then understanding VPBM for 2016. Next, preparing for the transition to MIPS and MACRA in 2017. And finally, we'll be going through how Spectrumetics can help your organization through our PQRS solution, which will identify your EPs, eligible professionals within the organization, help determine the PQRS measures that are ideal for you to report, whether individual or group, and talk about ongoing quality management and performance improvement, which can benefit your organization. Now I'd like to turn it over to Dr. Lakhanpal to begin the presentation.
Thank you, Mike, and good afternoon, everyone, or good morning and good afternoon, everyone. My name is Raj Lakhanpal, and it's a pleasure to present to you. So MIPS and MACRA have been in the news a lot, and MACRA is the proposed rule that becomes law soon. And MIPS is, as you can see at the bottom, is merit-based incentive payment system. What's happening is that 3 existing programs, PQRS, which has been there for a long time, has changed dramatically since last year or the previous year. Meaningful use compliance, been around for 4 or 5 years now, and then value-based payment modifier, which kicked in last year, VBPM, are all being rolled into one program to reduce the reporting burden on health systems and eligible professionals. So MIPS is a combination of all the 3 programs that we've talked about. Let me take each one of them. I'll start with PQRS, then go to VBPM, and then go to MIPS, so that I can explain how they are related and how it's a journey for you. So starting with PQRS, the PQRS, obviously, you have to report the CA for PQRS, and the reporting requirements are you got to report 9 measures across 3 domains, and most of you probably know that. And the deadlines for that are, if you're reporting as ECQMs, it'll be the end of February, so 2/28/2017. If you're reporting as a registry, it'll be 3/31/2017. But the registries will ask that you submit your results to them by early March, first week of March. So really your deadline is 3/1/2017. And at least you will have to report on at least one cross-cutting measure. And a cross-cutting measure is a measure that is broadly applicable to multiple EPs and groups. And an example of that is BMI screening. Another example is influenza immunizations. So these are two examples. And you'll be reporting from January 1, 2016 through December 31st, 2016. So over 12 months. I can't emphasize enough that if you have not started planning or planning to do so, please need to begin planning and execution now. You cannot wait till the end of the year for multiple reasons. We'll talk about that. And a little plug on Spectrometics on the slide. We support 169 PQRS measures, 23 measure groups, and we are certified by CMS for all the 64 EP-ECQMs as well. So who must report PQRS in 2016? Most of you are aware of this. All the Medicare physicians. So EP stands for eligible professionals, not eligible providers. So these are the eligible providers, Medicare physicians, DMs, MDs, DOs, all the ones, the first column, and the second column, the other practitioners, the EPs, PAs, nurse practitioners, clinical nurse specialists, CRNs, all of the professionals in the second column, and then the third column too, therapists, physical therapists, occupational therapists, speech therapists. They're all eligible. They are all eligible, and you have to report for them. If you're billing for them for Medicare Part B under your 10, then you have to report for them. That's the rule. Next slide. Okay, good. So you have two PQRS reporting options. One is you report as individual EP reporting option, and the second is the group reporting option, which is called GPRO. In both of these groups, or both of these options, you can report via ECQMs, and that's the first bullet, certified EHR technology. You can also report through a qualified PQRS registry, somebody like a Spectrometics, or you can report through a QCDR. And the difference between a QCDR and a qualified registry is that QCDR allows you to report on some custom measures. You can also report on the GPRO side, you can also report through a GPRO web interface, and the deadline for that is 6/30, 2016. So if you want to report through a GPRO, you have to let CMS know by 6/30 that that's how you're going to be doing. And then the survey measures apply to EP groups greater than 100. So those are the two reporting options. Now transitioning from PQRS to VBPM, excuse me. VBPM includes another complexity in terms of CMS has added cost measures for VBPM. And so on the left side, you see the measures. VBPM has PQRS, outcome measures, which CMS is able to calculate, patient survey measures for, again, groups greater than 100, and then cost measures. And, for you to know more about the cost measures, obviously CMS has claims, so they know how EPs are doing vis-a-vis, other groups. But more importantly, the cost measures, you can learn about how your group is performing through the QR/UR reports that you are getting from CMS twice a year. So what CMS does for VBPM is they look at the quality of care composite score, they calculate the cost of care composite score, and then it's a budget neutral program for CMS. So ultimately, if you have reported PQRS and you perform well in quality and you are, you've optimized your costs, you can have an upward adjustment. For groups of 2 to 9 EPs, the upward adjustment is either 2x or 1x. And let me point to the pointer with the pointer here, 2x or 1x. For 10 or more EPs, you could even have 4x to 2x to 4x. On the other side, for larger than 10 EPs, there could be a penalty. There's a penalty of 2% for not reporting PQRS, and it could be from -2% to -4%, or depending upon how you perform in quality and cost metrics. So now moving to MIPS. Oh no, I'm sorry, it's still on BBPM. BBPM, right now, whatever you report this year will apply to 2018. So as in the previous slide mentioned, 2x or 4x upward adjustment or penalty of 2 to 4%, and it applies to physicians and non-physician EPs greater than 2 EPs. So essentially, in a health system or a hospital or physician practice, it applies to everybody. And then physician and non-physician EP solo practitioners as well. So it not only applies to physicians, it applies to non-physicians this year as well. Now moving to MIPS. So the MIPS is just exactly, it's similar to VBPM. I'll talk about that. The penalties, just penalties or incentives, or penalties get magnified with MIPS. So the delta in performing well with MIPS is from plus 9% to minus 9%. So there's an 18% delta in terms of reimbursement in performing well vis-a-vis not performing well. And that starts in 2022, but it gradually goes up. Next slide, please. And this is how MIPS performance categories are calculated. You have quality. So there are 4 weighted performance categories on a scale from 0 to 100. And you have quality as number 1. It's going to be, some variation of the PQRS measures. The PQRS measures themselves. 2 is resource use. Again, the utilization that BBPM talks about or is taking into consideration the QR/UR reports that I talked about, and clinical practice improvement assessment, where physicians or the EPs would be provided a survey once a year where they evaluate how they're improving their practice. Also plays into HIE adoption, plays into clinical integration. So all those will account for that. And then advancing care information is the old meaningful use compliance. But now it also will take into consideration interoperability and how you're exchanging information with your colleagues as well. And that'll create a composite performance score. And this is where it'll be. In 2017, quality will account for 50%, cost will account for 10%, clinical practice improvement is 15%, and the old meaningful use compliance, advancing care information, will be 25%. In time, quality will go down, the weightage of quality will go down, and cost will go up. So I think even though cost is 10%, it's important to start taking cost into consideration. If we will be doing a follow-on webinar over the coming months on the cost implications for VBPM and MIPS. But if you have any questions, feel free to ask us today or, as a follow-up to this webinar. So why begin reporting process now? Most of you, I believe, have reported in the past. If you've not reported, it's very important to do a readiness assessment because first of all, it helps you determine your reporting option. Should you report as individual EPs or should you report with a GPRO option? It also helps you identify gaps in data and performance in time before submission, so you know where you stand. And also very importantly, helps you effectively determine measures to report. For those that that have generally done an annual reporting early part of the year, maybe January reporting or February reporting, I think it's very critical to start now because now you're into the VBPM that kicked off last year from 2015 reporting. So you are within VBPM. It applies to all your providers or EPs, and it is very important not only to report, but also try and see if you can improve quality and optimize costs. And also it'll help you transition. It'll set the stage for you to transition to MIPS from next year as well.
Thank you, Dr. Lockenthal. We're now going to have our first survey question. What method of PQRS reporting is your goal for 2016? So take a few minutes to answer, and I'll be back in a moment with the results. Thank you, everybody. Our results are in, and it looks like either you have not decided your reporting goal for next year, or you're going to report as a group through PRO, through a registry. Okay, now I'd like to introduce Mark Bryant to continue the presentation.
Thank you, Mike. So for my portion of the presentation, I'm going to tell you a little bit about us. I'm going to demonstrate a bit about our solution, and then talk to you about our process as a partner for our clients that are reporting PQRS. So to start, we facilitate, or we help health systems with the transition to fee-for-value and alternative payment models. And we do that in 3 core ways. The first is the ability to consolidate data across disparate systems. The second is the ability to calculate and report on measures for various hospital and ambulatory programs. And today I'll really focus on those 2 areas in terms of how do we capture data for PQRS reporting, and what measures are available, and how do you track those. And then the third piece is predictive analytics, and that applies both to inpatient, so for readmissions, value-based purchasing, HAC, HAI, and also population health analytics for risk stratification, geomapping, dynamic disease registries. We're not going to speak about those today, but if you have questions, we certainly can answer them separately. And at the bottom of this screen, or this presentation, you'll see a list of a few of our clients and relationships. We're happy to provide you a more extensive list if you wish. But just to highlight a couple, first to the left is Haney Solution, which is the division of Hospital Association in New York. Very proud of that relationship, where they've endorsed our PQRS solution to their members. If you're a New York-based hospital, please utilize them for advice on policy and other support. We're working with numerous clients like Greater Hudson Valley Health System and Allied Physicians of Michiana to report PQRS for 2015 and 2016. We're engaged in New York State DSRIP, which is a Medicaid reform program. We're engaged with 2 of their performing provider systems, 2 of their regions, in Staten Island Performing Provider System, and also Mount Sinai as well, providing various solutions, including data consolidation, a measure framework for maximizing incentives, and also analytics too. Again, happy to provide you a more extensive list later. So what is the solution that we can offer? The first stage is understanding your data sources, which I'll go into in subsequent slides. But we can give the ability to capture data, consolidate data, extract it, and harmonize from multiple sources, which can include your EMR data. It can include billing claims data. It can include survey data. We can integrate with HIEs, health information exchanges. We extract that data, transform it, harmonize it, and populate an enterprise data warehouse. And specific to the measures, we then layer our framework around it so that we can report for hospital programs. We're certified for all 29 hospital electronic clinical quality measures. So that allows us to satisfy HIQR, hospital inpatient quality reporting, meaningful use for the Joint Commission, value-based purchasing measures, any custom measures. And on the ambulatory side, we're certified for all 64 ECQMs, which can help you with PQRS and meaningful use if you choose to submit via ECQMs. We're also a qualified registry, and I'll show you what solutions we offer there in a second. We can support you accountable care organizations with their measures. We can support, like I stated, DISRUP with the measures that are associated with that Medicaid reform program. HEDIS measures, we were actually approached and selected by NCQA last summer to help them develop e-HEDIS measures as they make the transition to electronic submission, and will be certified later this year for STAR and hybrid measures. So we have, we feel we have a very strong competency in creating different measures and being able to help our clients track various quality programs both on the inpatient and the outpatient side. So as a qualified registry, we can support both individual eligible professional reporting, and that's either by ECQMs, by giving our clients the ability to look across 64 ECQMs, or as a qualified registry, we have 169 PQRS measures, and we support 23 measure groups as well. For GPRO reporting, for group reporting, we can again support ECQMs and also 169 PQRS measures. On our website is a full list of our PQRS measures. Also, we'll be sending out, as Mike has stated, a highlight deck of this presentation. Included in there will be a link to these measures as well. So it's crucial to be able to obviously get the right data and to capture that data and to then be able to report not only for PQRS but leverage the data potentially for other programs. And we see there's 3 different ways to in order to extract that data and ways that we can consume it for our clients. The first is in standard formats, HL7 standard formats, which could be a CCDA, a Consolidated Clinical Data Architect, or a QRDA. We can also take in billing data from 837P or 837I. We can provide, if a client wants to utilize clinical data but cannot get a standard format from their EMR or EMRs, we can provide what we call a data dictionary, so data specifications that we provide over to our clients so they can populate, pull the right data elements and then provide that back to us. Or we can build custom interfaces as well in order to extract data for our clients if they can't push out the standard formats. Once we have the data, we can populate an enterprise data warehouse from the measure framework, which I spoke about. I'm going to talk in the next slides about our performance improvement portal, which we believe is a differentiator we can offer. And then we handle the burden for all submission to CMS or to any other program, whether that's for PQRS, meaningful use, go back please, whether that's for accountable care organizations, for clinically integrated networks, for transformation clinical practice initiative, for any of the awardees underneath the TCPI program. We can take in data to satisfy any reporting requirement. So our portal that we'll offer our clients, again, is what we consider, we terminologize as a performance improvement tool. There's 4 key roles within that. We offer an executive role first. The executive role has the ability to track their measures from an aggregate, and that could be tracking it from a GPRO aggregate or tracking it from an individual eligible professional. So you can see the measures that have been selected for either reporting methodology and then be able to drill down to see comparisons. We can offer, down on the right-hand side, an analyst role. The analyst role is going to be able to go in and track the measures that you're looking to view the measures that you're looking to track for the year, and then be able to drill down into the patient-level details. And this gives the ability to do that true performance improvement. So if there's if the patient hasn't met the performance or there's data missing, that gives them the ability to correct that. Tied to that is an analyst role, a submitter role. So the submitter role would go in, if you're reporting ECQMs, would go in prior to the February 2017 deadline. If you're reporting via qualified registry, would go in prior to the March 2017 deadline. Be able to select the measures that are performing the best if you're tracking more than the 9 measures, and then be able to generate a report that's sent to us that we format to send on to CMS. That role would also have the ability to go back in for compliance and audit perspective to access that report at any time. And then finally, we can offer as an optional role, a provider role. So the provider can go in and track their patients from an aggregate and then drill down to see gaps in care and utilization, have a disease registry. And this is another way and I'm going to use the term again, performance improvement, but specific to providers where they can really look at their patients and look at them on an ongoing basis, how they're performing against the measures and see any of those gaps. And so for the sake of time, we didn't have, for the webinar, we didn't have an opportunity to show you a full demonstration, but I wanted to give you a couple quick snapshots of our portal. The first up top is the executive role. The executive role, again, can see as an aggregate and then drill down into the measures themselves. We'll offer within our portal two customizable benchmarks for the measures. They could be a national or state target. They could be an internal target. We'll work with our clients upon implementation to set those benchmarks. And then everything is color-coded. So if you're outperforming both benchmarks, it's in green. If you're underperforming an area, it's in orange. If you're underperforming both benchmarks, it would be in red for those measures. So that's the executive portal, kind of a quick look. And then from an analyst side, you'll see you're tracking a measure, hemoglobin A1C poor control. You'll see the denominator, whether performance is met, any exclusions, what's the performance rate. And then from there, the analyst is able to drill down into the patient-level details to see was performance met, was it not met, is there any information, is there any data missing? Now, if we're calculating it off of billing data, missing could be G codes, and where we could allow a smart web form here for the analyst to select the right G code, which would then populate the numerator. Or if we're using clinical data, we have a reason code next to that that states medication could be missing from the EHR. So that gives the ability to go back and correct that within the EHR. So with that, I'm going to turn it back over to Mike for our second survey question.
Thank you, Mark. Our second survey question is, what is your biggest challenge to reporting PQRS measures in 2016? So I'll give everybody a chance to answer, and we'll be right back. Thanks, everybody. It looks like the overwhelming answer to this question is that the biggest challenge is successfully extracting the data and data quality. Now I'd like to hand it back over to Mark to complete the presentation.
Thank you again, Mike. I appreciate everyone's participation in that question. So the next slide I'm going to show you fits right into the extraction of the data. And again, we thought it would be important to talk through the methodology because we know a lot of clients, a lot of people are struggling on accessing the data. So there's a couple ways, again, that we can assist. And that's first and foremost in a structured format, whether that's a QRDA or CCDA, directly from your EMR or EHR. We could take that in on an ongoing basis. The next is intelligent chart abstraction. What that means, we can support via billing and claims data or the smart web forms, which I talked a little bit about in the analyst role, populating information that may be missing like G codes within our portal. And the third is the non-standard format, and that could be custom interface into EHR. That could be us providing that data dictionary where we provide you the data elements per the measures that you're looking to track, and you provide us back a file to upload. And that could be other file uploads like Excels for EPs that are not utilizing an EMR to ingest that for you. So looking through, talking now into, how do we engage and how do we provide support for our clients, which is obviously the most important piece of this. We start off with what we call an assessment process. We'll have an initial discussion with your teams to understand how you reported last year, which way are you thinking of reporting this year, whether individually or group, any challenges that you've had in the past. What measures are you starting to consider to report for 2016? We'll then start to develop a plan. We'll go into a formal assessment process with you, a readiness assessment process, which Raj has stated earlier as a crucial piece we believe we can deliver, where we'll take in a sample amount of data, whether that's a month or a quarter's worth of data. We'll run it against the measures that you're looking to track for the year. We'll then give you a report back, sort of like the analyst view, but a report back up front that says, first, can you calculate at least 9 measures across 3 domains, first and foremost? And then second, how are you currently performing against those measures? What are the gaps in data? What are any current exclusions and exceptions? As we transition to the next slide, you'll see that we start off with the assessment. The deadline, if we start today and start working with you, we can help you make that decision whether you should report individually or group. We can support that. Once we get through the assessment, there's a remediation period for you to look at any gaps in data, start to work with improving the measures. If we can't get to 9 measures, we'll work with you to add additional measures to run an assessment against. During this time, we'll start the implementation, building out and customizing the portal and training you and your team on it. We'll then go live and then provide support throughout. So leading up to the submission period, providing the ongoing support for performance improvement, and then after, being your partner year over year to manage the services and support. And what that looks like is, the next slide is we handle any upgrades to the portal. We'll set up a batch process for ongoing data collection. The portal will give you the data governance and performance improvement aspects to look at on an ongoing basis. We'll handle all submission. We take the burden off to submit to CMS or to any program. If there's changes in the measures, if new measures are added or there's changes in the measure specs, we'll upgrade those measures. And if the measures changing causes that new data needs to be captured, we'll then also work with you to capture that data. And not only do we want to support you through the governance of collecting the data and changing the measure, but we want to be your partner as we transition and help you transition to MIPS. And as Raj had stated earlier, there's 4 key areas, but honing in on a couple is we have the competencies to build the measures and calculate the measures for you as they're developed by MIPS today and going forward. We can utilize clinical billing data to do cost and utilization analytics. And we also can provide the benchmarking for you that's going to be necessary. And we're doing that today. We're doing that for New York State District programs. We're doing that for PQRS today for our clients. We're doing that for TCPI, the Transformation of Clinical Practice Initiative awardee that we're working with, and other programs. So we have the ability to give you that benchmarking for continued performance improvement. And to summarize our capabilities, we want to be your partner to help not only for PQRS reporting today, whether that's through ECQMs or via us being a qualified registry. We can support your eligible professionals that are not documenting in your EHRs, because we know that's still a challenge. If you have multiple tax identification numbers you're looking to report on, we can handle. We can provide you a solution that not only can report on those TINs, but we can provide you through our portal the means to customize it to be able to track multiple TINs, multiple programs on the hospital and the ambulatory side, and give you that tool to look on an ongoing basis to improve your performance and maximize your incentives. And we can, support submission for EH and EP programs to CMS, to the Joint Commission, and NCQA. And overall, we want to be that, your long-term partner, help you transition to MIPS, and, most importantly, maximize your incentives. So with that, we're going to start our question and answer session. Joining us for this is our eMeasures 360 product manager, Kumar Kondasamy. And with that, I'm going to turn it back over to Mike to facilitate the Q&A session.
Thank you, Mark and Dr. Lockenpaul. As Mark stated, we'll now begin the Q&A session. We had a number of excellent questions come through during the webinar, but also feel free to keep sending them. So our first question is, Can you provide a few examples of measures that a hospital-based EP should report?
Yeah, that's a good question. So before I start answering the question, hospital EPs are eligible for PQRS. Specialty, for example, CRNAs, hospitalists, ED physicians, anesthesiologists are eligible, and they have to report PQRS. Some of the measures that are recommended are like medication reconciliation, documentation of current medications in the EHR. Also, any preventive care measures, screening measures are also some of the recommended measures for hospital-based.
Thank you, Kumar. Next question. Once I select SpectraMedics for 2016 PQRS reporting, when would we need to begin the process?
So the short answer is it's better to start right now, because the decision, because you need to let CMS know by end of June whether you plan to report through a group or as an individual EP, and that's a big decision. And because once you make the decision, you can't go back and change it. So we've seen cases of other physician groups where they sometime in the end of Q3, Q4, they figured out they were not able to do individual, but there's no way to go back and change that to individual to group. So in short, it's better to start the process right now, so you have a better understanding of your data, of the measures that you want to report, and also have a process in place to capture those data.
Thank you again. Next question. How does your solution help with improving data quality?
Good. So starts with the readiness assessment. During readiness assessment, we do look at both your data from billing system as well as your clinical system, EHR, practice management system, whatever you have in place, and that helps us to see where you are with the data quality. We also let you know what issues we are facing or we found with the data. That way you have, you can start working on remediating those issues. And then once we go live with the solution, we provide dashboards and analytics which looks at tracking the performance on an ongoing basis. So we collect data on a frequent basis, calculate the measures, so that you can look at your performance, as you go through the reporting period, and that way you can eliminate any surprises, at the time of submission.
The next question is, are critical access hospitals required?
Yes. So critical hospital, access hospitals, CAH, are required. And especially the method 2 hospitals are required to report PQRS. What we highly recommend is contacting your CMS or your payer to make sure which providers in the critical access hospitals are eligible. Especially the method 2 billing system.
Some additional questions.
So how often does Spectra extract data from CMS daily, monthly, weekly? So we extract data not from CMS, but from our physician groups, hospitals, and that data is being used for calculating measures. On an ongoing basis, we collect data on a monthly. But during the time of submission, we do support ad hoc requests. So if you find any issues, you let us know. We should be able to get an updated extract to calculate those measures.
Next question is, in identifying EPs to report, is the sole criteria for an EP submitting Medicare claims within a given TIN?
No, it starts with Medicare Part B billing, but it also looks at the number of patients you serve during the period, And also, if you are part of, if an NPI is part of multiple TINs, they still have to report on the TIN. So if you have any questions on who's eligible apart from your employed full-time physicians, like your locums, independent physicians, it's better to reach out to CMS to clarify those.
Thank you. Our next question, will the system track measures for HMO like Fidelis?
Yes, we do. We do support measures that are PQRS, non-PQRS for other programs. For example, we do support clinically integrated network program, which is currently used by Mount Sinai, and that includes a lot of PQRS measures, also custom measures that are part of the program. So in short, yes, we can customize programs based on the requirements.
Next, how long does it take from the time you sign up to the time you go live?
So our typical implementation phase lasts from 4 to 6 weeks. That depends on how soon we can get our hands on the data. So for example, if you have claims for say first quarter, then to March. Also, if you have EHR data for your physicians, we can start the process right away and then have the portal up and running in 4 weeks. But for example, if the data is missing, you need more time to remediate those gaps based on the measures you select. That would increase the the time to go live.
Okay, I think time for one or two more. For 2017 reporting as part of MIPS, it was mentioned that hospitals are excluded. How does this impact physicians that practice in the hospital setting and are under the same TIN as our clinic?
That's a good question. So for 2017, only physicians are required to report for MIPS. The non-physicians are not required. Now, again, these are all proposed rules. We have to wait until fall to really understand the requirements. Right now everything is proposed, and we have to see what comments that hospital physicians are going to raise. But physicians, if they are part of a specialty, they have to report. That's the current requirement. And if they have part of multiple TINs, they have to report on the each.
Okay, and finally, I assume you are software as a service. What is the rough cost associated with that service?
Yes, we are a software as a service. We're a cloud-hosted environment. We charge by an implementation, customization implementation fee, and also we have a per eligible professional fee as well. I'm happy to discuss that separately depending on the volume of MIPS that you have to report.
Okay, one more question here. Can custom extracts be defined and delivered to support ad hoc analytics beyond required regulatory submissions?
Yes. Again, our portal is highly customizable. We also offer other analytic tools and dashboards where you would have the ability to go in and run different type of reporting within it. We can do custom or canned reporting for you, but we can also give you ad hoc reporting within the tool. I'm happy to show you that separately.
Just to add to that, we also support export of data in a CSV or Excel format. So if you have any tools in place, you can export the data from our system and analyze the data using your existing tools.
And with that, I think that's it for all of our questions. We greatly appreciate all of your time today and your questions and your great feedback through the polls. If you have any additional questions for us or you're interested in support for PQRS reporting in 2016 and beyond, we greatly appreciate the opportunity. My information, Mark Bryant, is up on the screen, and we'll be sending you a highlighted deck after this that'll include my information as well. So Appreciate your time, and we look forward to speaking with you again. Have a great day.